Okay, so now we're going into week 5, and will cover oxygenation, gastrointestinal, and your system. So your oxygenation you will find in Pattern Perry chapter 40, and you will have anywhere from 6 to 7 questions from this chapter. So it is a pretty important chapter to make sure you understand very well. And part of the reason why oxygenation is very important is because we're also going to talk about your cardiac here, and it's going to be a topic that you're going to see for the remainder of the course. You're going to see it in 201, and you're also going to see it in advanced. So we want to make sure that you get a very good grasp on oxygenation. And part of the reason is, as we know, oxygenation is a basic human need. We need this to continue to live. And patients frequently when they're unable to meet their oxygenation needs, they either have an issue with impaired gas exchange, which can be a respiratory problem, or they can also have cardiac problems, which would cause an ineffective pump. And we're going to go over those two different types of problems. So the very first thing you need is to have a base on the science behind it. We know that oxygen is needed to live, and the cardiac and respiratory system, supply the oxygen demands for the body, and they work hand in hand. The exchange of respiratory gases occurs between the environment and the blood. Respiration is the exchange of oxygen and carbon dioxide during cellular metabolism. And neural and chemical regulators in our brain control the rate and depth of respiration in response to what our body needs. We don't have any control over it. It is automatic. And sometimes when people are have advanced airway, we can manage that for them if they're on life support. And the this should be a review for most of you from either physiology or pathophysiology. Remember also that the full cardiovascular system provides transport mechanisms that distribute oxygen to cells and all the tissues of the body. So some of the physiology when it comes to respiratory, this picture here is giving you a diagram on how the air goes in and how it's exchanged with the alveoli. We know that the main function of the lungs is for us to get oxygen from the atmosphere. It goes into the alveoli, and the waste product that comes out is our carbon dioxide. We have the airways of the lung, which transfer oxygen from the atmosphere to the alveoli, where the oxygen at that point is exchanged to carbon dioxide. Pretty much when going over the function of the lung again. And throughout the alveolar capillary membrane, oxygen transfers to the blood and carbon dioxide transfers from the alveoli. So as you can see, the alveoli play a huge role in gas exchange, and usually when patients run into conditions having to do with infections such as let's say a pneumonia, these little alveoli many times collapse and become full of exudate. And this is why exchange of oxygen cannot take place and the patient comes in feeling shortness of breath. And there's other conditions too that can affect this. The respiratory is a muscle. There's a pleural space in between. We have muscles. We have our diaphragm, which is a huge muscle that can also be affected. We have pleural space, lungs, and the alveoli. All of these are very important when we talk about ventilation, perfusion, and exchanges of gases. We know that gas moves in and we have pressures. We have the intrapleural pressure, which is inside our lungs, is negative, which is less than our atmosphere's pressure. It's anywhere from maybe 760 millimoles of mercury at sea level. For air to flow into the lungs, intrapleural pressure becomes more negative, and setting up a pressure gradient between the atmosphere and the alveoli. So this diagram you will also see in your textbook on page 822. Steps in oxygenation. I did mention on the previous slide, we have ventilation, perfusion, and diffusion. These are the three steps that are involved in our process with oxygenation. Ventilation is a process that is going to move gases in and out of the lungs. And then we have perfusion. This is a term you're going to hear quite often in nursing. We always say tissues are not getting adequately perfused. That just means that our cardiovascular system pump, or which has oxygenated blood, is not being delivered to the tissues during circulatory. So that can either happen when people are in shock or there's some impairment going on, and diffusion as well, which is exchange of respiratory gases in the alveoli and capillaries. On this slide, we just have some terminology that you should be aware of. So the first one is workup breathing. That's just the effort required to expand and contract the lungs. Inspiration and expiration, just in and out, taking your breath in, taking the breath out. Surfactant, which you will also learn when you do pediatrics or OB, if you get to do those classes. With the surfactant, it's just a chemical that is produced in our lungs to maintain the surface tension of the alveoli that keeps them from collapsing. And how you can relate this to a neonate is when a mother is going into preterm labor, many times they will give her surfactant to help the baby's lungs mature, because they don't have the surfactant. So if they're born and they do not have enough surfactant, then all of their old alveoli are going to collapse and they're not going to be able to have proper air exchange. Then you have atelectasis, which is collapse of the alveoli, which can happen with pneumonia is a common one. Also, you can have let me think of another one. And usually when I think about atelectasis, I just think about pneumonia is the first one that pops in my head. But with atelectasis, like I said, it's a collapse of the alveoli. It prevents normal exchange of oxygen and carbon dioxide. And then compliance is just ability of the lungs to stretch. When certain diseases such as ARDS, which is advanced respiratory distress syndrome, some of these lungs lose that compliance. So it's just how the ability of the stretch of the lungs. And it's going as far as how you can relate this to patients. Patients with COPD, they lose the recoil of the lungs and the thorax. And that is a reason why they have an increased workup breathing. When you see some of these COPD patients, many of them will have pursed lip breathing. They have to sit up to breathe. They're upright, especially if they have emphysema. They have the barrel chest. Then you have inspiration, which is active process, and that's stimulated by chemical receptors in the aorta. You do it without thinking about it. And expiration is passive. That takes no effort. So inspiration takes effort, expiration does not take any effort. And then compliance, I talked about compliance, on how that is this ability of being able to expand. And we also have airway resistance, which I didn't go over too much earlier, but with airway resistance, what that is increase in pressures that occur as the diameter of the airways decreases from mouth, nose to alveoli. Any further decrease in the airway diameter, like bronchoconstriction, that can happen with people that have asthma, or if you just think about any disease that can cause any type of airway obstruction. That's airway resistance. And if airway resistance gets too high, the amount of oxygen that's delivered to the alveoli decreases. And remember, in the first slides, if you have non-functioning alveoli, gas exchange is not going to take place. Here's a little bit more of physiology, and think I'm gonna let you read this one in the book because there is a lot of information, and the reason why this one is important is because it'll help you be able to relate. If you know the physiology about it, you can relate it to the disease processes of your patients. With this one, it's going more in detail with what's going on with respiratory exchange. So if we think about diffusion again, remember diffusion is a process of exchange of respiratory gases in the alveoli and the capillaries of the body tissues. Diffusion of respiratory gases occurs at the alveolar capillary membrane. So if you look at the picture, you can see the alveoli right there. Increased thickness of the membrane impedes diffusion because gases take longer to transfer across the membrane. Patients with pulmonary edema, and if you ever think about pulmonary edema, a classic sign of pulmonary edema is pink frothy sputum. That's usually a patient that has fluid overloaded. Can be someone that has congestive heart failure. Then we can also talk about pulmonary infiltrates, which you can see that in X-ray patients with pneumonia, or pulmonary effusions. These have like a thick membrane, and it slows down the diffusion. So in other words, it slows down the exchange of gases, which at endpoint is low delivery of oxygen to our tissues. And if we think about that terminology again, now we're talking about our tissues are not getting perfused. Some chronic diseases again that I could think of is like pneumothorax, emphysema, and there is surgical procedures of lobectomy. And if you think about ectomy is removal, lobectomy or removal of the lobes, which sometimes is a surgical procedure that's done to patients that have end-stage COPD or can also have tumors. Remember that the oxygen transport system consists of lungs and cardiovascular, and that's why we're going to cover cardiovascular along with this chapter. Do keep in mind, as far as testing goes, respiratory will be the bulk of the questions. I'm not really going to ask you too many questions on cardiac, which I believe I may only ask you one or two. The reason why is because I'm in the syllabus, it's concentrating more on oxygen. So anyhow, going back to here, if we think about the delivery system, remember it depends on how much oxygen is coming into the lungs, which means ventilation. Blood flow to the lungs and tissues, once again perfusion, remember tissue perfusion. The rate of diffusion and oxygen carrying capacity. Three things influence the capacity of blood to carry oxygen: the amount of dissolved oxygen that's being carried in the plasma, the amount of hemoglobin, because remember, hemoglobin is what carries our oxygen, and the tendency of the hemoglobin to bind. The oxygen will bind into the hemoglobin. Hemoglobin, which is a carrier of oxygen and carbon dioxide, transports most oxygen, which is 97%. The hemoglobin molecule combines with oxygen to form oxyhemoglobin. And the formation of oxyhemoglobin is easily reversible, allowing hemoglobin and oxygen to dissociate, meaning it frees oxygen to enter the tissues. When someone has a decreased hemoglobin, it alters their ability to transport oxygen, so they can have decreased tissue perfusion. Carbon dioxide, which is a product of cellular metabolism, diffuses into red blood cells and rapidly hydrates into carbonic acid, H2CO3. At that point, the carbonic acid then dissociates into hydrogen and bicarbonate ions, HCO3. The hemoglobin buffers the hydrogen ion and the bicarbonate, which diffuses into the plasma. And once again, if we're talking about reduced hemoglobin combines with carbon dioxide, and venous blood transports most of the carbon dioxide back to the lungs to be exhaled. So that is your entire respiratory system in a nutshell. Your book has great information, so make sure you do read that portion of your book. Now, regulation of respiration. Regulation of respiration is necessary to ensure sufficient oxygen is coming in and enough carbon dioxide is being eliminated. Neural and chemical regulators control the process of respiration. Neural regulation is controlled by the central nervous system of respiratory rate. It will control the rate, the depth, and the rhythm. The cerebral cortex regulates the voluntary control of respiration by delivering impulses to the respiratory motor neurons by the way of the spinal cord. Chemical regulation maintains appropriate rate and depth of respirations. It's all based on how much CO2 and oxygen we have, and hydrogen ions as well in the blood. And the way where I can give you an example is, let's say you have a patient that is acidotic, meaning their pH in their blood is less than 7.35. Normal pH in our blood is 7.35 to 7.45. If your body senses that it's in an acidotic state, it's automatically going to make you breathe faster because it wants you to blow out the CO2. Blowing out the CO2 will make you become more on the base side, and then your acid is being eliminated, and you're going to start regulating the pH in your blood. Our body does not like to very much dislikes not being regulated, so it will do whatever it has to do to make sure that your system is becoming regulated by whatever means it needs to. Now a little bit of cardiovascular physiology. The cardiac system, we know, delivers oxygen, nutrients, and other substances to the tissues by the process, of course, our circulation, and facilitates the removal of cellular waste. All of this is done through our blood flow, and are the two systems that take a big role in this is obviously our respiratory and our cardiac. But we also have our digestive and our renal system that also take a role in this. The primary function of the heart, we know, is to deliver deoxygenated blood to the lungs for oxygenation, and oxygen and nutrients to the rest of the body and the rest of the tissues. And this is just a diagram showing you the different chambers. We know that we have 4 different chambers. We have 2 in the atria side and 2 ventricles. We know the atria are in the top and the ventricles are in the bottom. If you just think about the path on how blood flow goes, we know that the right ventricle will pump deoxygenated blood into the pulmonary circulation, and you could take a look at that right at the diagram. The left ventricle pumps oxygenated blood back into the body, and as blood is passing through this circulatory system, it's doing an exchange of respiratory gases, nutrients, and waste products that are occurring between the blood and the tissues. The right ventricle pumps blood through the pulmonary circulation. The left ventricle pumps blood through the systemic circulation. So if you think about it that way, we're going to talk about right and left-sided heart failure. If you can just remember that the right goes into the pulmonary system and the left is the systemic blood in our circulation. And here is a little bit more patho on that. We know that our heart, the main role of the heart is to give our body oxygenated blood and get oxygen from our lungs and push it out through the left ventricle to the entire body. So the ventricles are going to fill with blood, which happens during diastole, and then they're going to empty during systole. That's your lub-dub. The myocardial fibers have contractile properties that allow them to stretch during filling. That's the Starling's law. And when a heart is diseased, the Starling law does not apply because the increased stretch of the myocardium is beyond what that damaged heart can do. Usually people that have had an MI or people that have cardiomyopathy. The subsequent contractile response results in insufficient stroke volume. So meaning that blood is not being pumped out, and if it's not being pumped out, then it's backing up. and when it backs up, it goes into the pulmonary system, which at that point is called left heart failure, or systemic right heart failure circulation. To maintain adequate blood flow to the pulmonary and systemic circulation, myocardial blood flow must supply sufficient oxygen and nutrients to the myocardium itself. So blood flows through the heart in unidirectional. The four heart valves ensure this forward blood flow. During ventricular diastole, the atrioventricular, mitral, and tricuspid valves open and blood flows from area of higher pressure, which is the atrium, to the relaxed ventricles. As systole begins, the ventricle pressure rises and closes the mitral and tricuspid valves. Valve closure causes the first heart sound, which is your leb. That's your S1. Remember, we have an S1 and an S2. During the systolic phase, the semilunar valves, which is your aortic or pulmonic valves, they open, and blood flows from the ventricles into the aorta and pulmonary artery. The mitral and tricuspid valves stay closed during systole, so all the blood is moved forward into the pulmonary artery and aorta. As the ventricles empty, ventricle pressure decrease, allowing closure of the aortic and pulmonic valves, which at that point you're going to hear your S2 that causes the second heart sound. Patients that have valvular diseases will end up having a backflow because these valves will not completely close. So there's always like a leakage, and many times when you auscultate, you can hear a murmur because they have an incompetent valve. The coronary circulation is a branch of the systemic circulation that supplies the myocardium with oxygen and nutrients and removes waste. It is a lot, but it is important. It is going to play a huge role when you do 201. So if you are rusty with this information, I highly recommend that you do read this chapter as best as you can. Okay. And now we're going to talk about blood flow regulation. With cardiac output, a healthy heart has anywhere to 4 to 6 liters. That's your cardiac output, 4 to 6. And that's at rest. The volume of blood ejected from the ventricles during systole is the stroke volume. So if you think about which cardiac output will be, it's going to be stroke volume times heart rate. Hemorrhagic and dehydration cause a decrease in circulation, blood volume, and decrease in stroke volume. The amount of blood that's in the left ventricle at the end of diastole is known as your preload. Resistance to the left ventricular ejection is your afterload. So remember your preload and afterload. And like I said, this is primarily when you go to intermediate med-surg. You're going to learn about more on preload and afterload. So remember, preload is the amount of blood in the left ventricle at the end of diastole, and afterload is the resistance to the left ventricle ejection. Myocardial contractility, all that will affect stroke volume. Heart rate affects blood flow because of the relationship between rate and diastolic filling time. Here is just a diagram showing you the conduction system. You can find this diagram along with explanations in page 825. So our normal heart rate is known as normal sinus rhythm. The very first conduction begins in the SA node, which you look at the diagram right on top right there, SA node, and then it's going to follow a normal sequence through the conduction system. So rhythmic relaxation and contraction of the atria and ventricles depend on continuous organized transmission of electrical impulses. The cardiac conduction system generates and transmits these impulses. The conduction system originates with the SA node, which is also known as the pacemaker of the heart. So when you have patients that have pacemaker, that's usually because their SA node is not firing anymore, so they need a pacemaker to do the fire from the SA node. The SA node is in the right atrium next to the entrance of the superior vena cava. Impulses are initiated there when on the SA node, and at usually an intrinsic rate of 75. And that's so a rate of 75 will cause a cardiac action potential per minute. in an adult at rest. Electrical impulses are transmitted through the atria along intra-atrial pathways to the AV node. The AV node mediates impulses, and if you look at the picture, you can see where the AV node is. Then it goes straight down and can branch out. So with the AV node mediates impulses between the atria and the ventricles. It assists atrial emptying by delaying the impulse before transmitting it to the bundle of His. And if you look at the picture, you can see the bundle of His and the ventricular Purkinje network. So a little bit more on the conduction system. Excuse me, just did a little yawn. Okay, normal sinus rhythm originates at the SA node and follows the normal sequence through the conduction system. So the conduction system of the heart generates these impulses needed to initiate the electrical chain of events for a normal heartbeat. You have the autonomic nervous system, which influences the rate of impulse generating or generation at the speed of transmission through the conductive pathways and the strength of atrial and ventricular contractions. Then you have systematic and parasympathetic nerve fibers in the radial parts of the atria and ventricles and the SA and AV nodes. Sympathetic fibers increase the rate of impulse generating the speed of transmission. Parasympathetic fibers will originate from the vagus nerve, which decreases the heart rate. There are many instances where you can have a patient that will bear down and give themselves what they call a vasovagal. So when a patient gives themselves a vasovagal, keep in mind that that will immediately decrease the rate of the heart. If you have a patient on a monitor and all of a sudden you see them decrease, go and assess them, and many times than not, they've actually given themselves a vasovagal response. We have actually had people go into cardiac arrest from a vasovagal, and that's usually people that do not have, they have already a pump that's affected, so the pump cannot effectively go back into its rhythm after a vasovagal response. Don't know if you've ever heard of many people will die in the toilet. If you talk to an EMT or a paramedic, they'll tell you that I have found many people sitting in the toilet that have deceased because of the same thing. They'll create a vasovagal response that will decrease their heart rate to very low levels at times. Okay, this diagram here is giving you the waveform of a normal heart rate. You have everything that you need there. You have your P wave, you have your PR interval, your QRS, your ST interval, and your T, and you also have your QT. So an ECG, which is also known as electrocardiogram, will always give you the electrical activity of the conduction system that's going on in your patient's heart. We use ECGs constantly for many different reasons. We can use it as a diagnostic for someone that perhaps had an MI. Right there, that section where you see ST, there's MIs that can cause an ST elevation. And then you have non-ST elevation MI, which is not as urgent as an ST elevation. If you ever hear a patient having an ST elevation MI, that is someone that needs to be taken into the cath lab because they may be anywhere from 95 to 100% occluded in one of their coronary arteries. So when you, going back to your waveform here, when you hear the term normal sinus rhythm, that implies that there was an impulse that was originated from the SA node. Remember, the SA node is a natural pacemaker of the heart. And this is your normal conduction system. So when you think about the electrical activity from the previous slide, this is what it's going to create. So the P wave represents electrical conduction through both atrias. Then you have the PR interval, which represents The impulse travel time from the AV node to the bundle of His and Purkinje fibers. The length of the PR interval normal is anywhere from 0.12 to 0.20. Anything greater than that usually means there's some kind of dysrhythmia going on. The QRS is the duration of electrical impulse as it travels through the ventricles. Should be anywhere from 0.06 to 0.012. Any prolongation in your QRS greater than 0.12 usually indicates some kind of dysrhythmia as well. And your QT interval represents the time needed for the ventricle depolarization and repolarization. So that's towards the end of the conduction system. So what kind of things are going to affect this? You have any conditions that can affect the cardiopulmonary function will directly affect the needs. Anything that can cause some decreased oxygen carrying capacity, hypovolemia, not enough volume, decreased inspired oxygen concentration, increased metabolic rate, someone that can sick have an infection. Things that can affect the wall, which remember we talked about the diaphragm, can be pregnancy, obesity, neuromuscular diseases, muscular abnormalities, trauma, central nervous alterations. There's diseases that can affect our respiratory, which are nervous system related. I don't know if how many of you are familiar with myasthenia gravis, Guillain-Barré. And do remember when patients take opiates, the respiratory center is depressed. Alterations in respiratory function. With this one we have hyperventilation, hypoventilation, hypoxia, and cyanosis. Cyanosis is always a late sign. So make sure that your patients never go into cyanosis, because if they did, that means you missed all the premature signs. So the very first thing, you're going to see is someone will start hyperventilating. And that can either be caused by anxiety, some kind of infection, drugs, acid-base imbalances. So let's say your patient has too much acid. It can be acidotic. Fever. With fever, it's also going to do the same. Aspirin poisoning or amphetamine use. And remember, as I mentioned before, respiratory is usually affected because the body will create a response of increased respiratory rate to eliminate the carbon dioxide. Hypoventilation, which many patients will do post-op because it hurts to breathe. However, it comes with problems. If your patient is hypoventilating, it's going to cause atelectasis, and it's going to collapse those little alveoli. And if we remember earlier, if these little alveoli are collapsed, there's going to be no air exchange. Hypoxia is a life-threatening. It can either be caused by carbon monoxide, anemia, shock, septic shock, cyanide poisoning, pneumonia, atelectasis, cardiomyopathy, head injury. And then we're going down to cyanosis now. At this point where your patient is cyanotic, now you're going to start seeing the blue discoloration of the skin and mucous membranes, which is caused because there's desaturated hemoglobin in our capillaries. Remember, it's always a late sign. One of the first signs too is confusion for patients. So let's say you have a patient that has been intact all along while you've been taking care of them. Now all of a sudden Mr. Smith starts getting confused on us. It's not because he has sundowners, it's because there's something wrong with his respiratory. So you need to go back and evaluate and see what are the things, what is he doing. Look at his signs and symptoms of how he's behaving. Let's do an oxygen saturation. You might even need to do an ABG, and that's when you can really find problems that's going on with your patient. Okay, in this slide we're going to go over alterations in cardiac function. The first one is disturbances in conduction, and that's usually anything that can affect electrical impulses that usually do not originate from the SA node, which would be dysrhythmias. We have different illnesses and conditions that can affect our cardiac rate and rhythm, how our heart contracts, and how the blood flow goes through the chambers and into our peripheral circulation. All of these can alter cardiac function. There's dysrhythmia such as VTAC, ventricular tachycardia, ventricular fibrillation. These are life-threatening rhythms that require immediate intervention. And as nurses, we're supposed to uh, be able to assess these and catch them early so intervention can occur. Ventricular tachycardia, as mentioned, is a dysrhythmia. It is life-threatening. This one decreases cardiac output, so it deteriorates ventricular. It can go into ventricular fibrillation, or it can also cause sudden cardiac death. Now, as far as altered cardiac output, that's just meaning insufficient volume is ejected into the systemic and pulmonary circulation. That's usually something that can occur through left-sided failure or right-sided failure as well. Now, as far as your valves, if there's a dysfunction in the valves, I mentioned earlier that you can have backflow. If you have backflow, that means when you're auscultating your patient, you will either hear a murmur or a whooshing sound. They're very loud. If you ever have a patient with a valvular disorder, you will be able to listen to this, and it's a sound that you really can't compare to anything else. Another alteration can be MIs, coronary artery flow. All of this, if this is impaired, there's going to be um, insufficient oxygenation to meet the demands of the body. With angina pectoris, that's just some kind of imbalance between myocardial oxygen supply and demand, and it can just be chest discomfort. Doesn't mean that you have had an MI. It can simply be you having angina episodes. MI and acute coronary syndrome. These can happen with decreases through our coronary blood flow, or an increase of oxygen demands without enough coronary perfusion. Common MI diseases include angina, MI, acute coronary syndrome, also known as ACS. And remember, ACS is different from angina. Acute coronary syndrome includes unstable angina. There's a difference between stable and unstable angina, but we're not going to talk about that. It's too advanced for this course. There's also non-ST elevation MI and ST elevation MI, and I went over a little bit when I showed you the normal sinus rhythm. So what do we need to know? There's all these different factors influence oxygenation. Different things such as physiological, development, lifestyle, environmental, and we're actually going to go through each one so you can see what kind of things affect this. With developmental factors, we have infants and toddlers. We have school-age children, adolescents, young and middle adults, and older adults. As far as problems with infants and toddlers, they tend to get a lot of respiratory infections, primarily upper. Sometimes they'll also have some nasal congestion. And with your school-aged kids and adolescents, they do have a lot of exposure to respiratory infections. Can also have secondary hand smoke. And as far as some adolescents, they can also start smoking during their adolescent time. When it comes to young to middle adults, usually at this point they can have things such as diet, lack of exercise, stress, people that smoke, illegal substances, any type of prescription drugs that are not being used correctly, and stuff that's over the counter as well. With older adults, you have age-related changes of the immune system that can lead, they're at a higher risk for infection. They also have calcification of their valves. They have problems with their SA node, osteoporosis. They have enlarged alveoli, trachea, and bronchi. You can look, there is a little box in your book. It's box 41. It has changes in the older adult for you to see some more differences and more in-depth information. Some lifestyle factors. We have nutrition. With nutrition and exercise, these are modifiable risk factors because we know that we can change the way we eat. We can also add exercise to our daily regimen. There's a lot of lifestyle modifications that can be changed, such as cigarette smoking. We know cigarette smoking causes problems with respiratory and cardiac system, and that is modifiable because we can change it. We can go into a smoking cessation program. As far as weight is concerned, there can be a weight reduction program. Diet, go into a low cholesterol, low sodium diet. Manage the blood pressure and include exercise. As nurses, we play a big role teaching our patients prevention. So it's important to know all the different things that we can teach our patients. That way we can avoid them from going into complications. As here are some more risk factors. We know smoking because, like I mentioned, has a relationship with heart disease, COPD, lung cancer. People who smoke are 10 times greater of risk of getting lung cancer versus someone who doesn't smoke. Substance abuse, excessive alcohol and other drugs impair tissue oxygenation. Stress, when our body is in continual stress, it causes severe anxiety, which it can increase metabolic rate and oxygen demands of the body. Other things that can affect lifestyle risk factors, women that take birth control pills, it affects their clotting factors. And if they smoke and take birth control pills, it's a very bad combination. It gives them a very high risk of thrombophlebitis and PE. And of course, exposure to secondhand smoke is also a risk factor. And we're talking about anxiety. As far as anxiety, it's important for the person to be able to adapt to the different kind of stresses that they may encounter. When someone is going through difficult stress, as mentioned before, they cannot tolerate the oxygen demands associated with anxiety, and they'll become short of breath. And then the problem is when they become short of breath, then once again they become even more short of breath. As far as environment goes, depending on where people work, there can be occupational pollutants. People that worked with asbestos, dust, airborne fibers, talcum powder, different things can affect people's respiratory. Farm workers, they're working in dry areas. They can get fungal infections from the dirt. They can inhale the spores that are in dirt. There's valley fever. There's another disease called coccidioiditis immitis, asbestos again, and there is a high risk with asbestos with lung cancer, and of course tobacco exposure to tobacco smoke. When it comes to assessment, it's very important to have really good assessment skills with these patients because many of them have different disease processes going on. So it's important that we thoroughly assess every patient, make sure we're critically analyzing them, ask patients about what they expect from their health visit. It's important to include them in their plan of care. Make sure when we are developing goals that they're short and they're realistic. Remember that take any opportunity you possibly can to educate your patient, whether you do it face to face, you can also do it over the phone, in person. Give them information for them to become educated and help them prevent any complications from their chronic diseases. Make sure that you're teaching about food and drug or any allergies, and look at different laboratory and diagnostic tests. Just look at the picture and look at the whole picture, not just one side effect or one test result. Here's a little bit more about assessment history, and this one does go in depth, and I do want you to know what kind of things you're going to ask and what kind of things you're going to be looking for. We know that with chest pain is usually one of those things. If someone comes in through the ED, we need to evaluate them immediately. This is not someone who needs to wait, because the longer we make them wait, they can either die on us or complicate. If they're having an MI, we can complicate the MI. There's a lot of interventions that are time-based, so it's important to get this patient in and evaluated immediately. As far as fatigue in patients with cardiopulmonary problems is usually an early sign that they're becoming worse, so it's important to look into that. Dyspnea is one of those clinical signs that is letting you know that your patient is becoming hypoxic. With these patients, they'll become they'll have this very uncomfortable feeling that they cannot breathe, and it's it's uncomfortable breathing. You can have objective signs that you'll see that they're going through dyspnea. They'll be doing pursed lip breathing. They'll grunt before they exhale. You'll see them using their accessory muscles to breathe. Orthopnea is usually something that people that have heart failure, which typically begins on the left side. That means they're just sleeping with multiple pillows because they have to be reclining in order to breathe. Patients with chronic cough tend to deny or underestimate or minimize their coughing, often because they're so used to it that they're not aware that it's abnormal, that they're always coughing. And remember, with cough, it can be related to, that's when you would assess the medications, because maybe they're on ACE inhibitor. Remember, ACE inhibitors can cause an annoying cough. And if they're having any kind of hemoptysis, we need to determine if there's coughing or bleeding going on, what kind of sinus drainage. Wheezing, we know it's a sign of narrowed airway, usually associated with asthma, bronchitis, pneumonia. Also, as far as smoking, we need to know whether they are the smoker or are they second-hand. It's important to always ask if there's anybody in the family that does smoke, because then we know that our patient is being exposed to secondary hand smoke. And we need to get history on how often they're getting respiratory infections, because that's a big clue on what can be going on with them. And as far as when we're looking for allergies, ask specific questions as far as what kind of reaction they had, because a lot of people will say they're allergic to certain medications. It's not that they're allergic, they just had a side effect. So remember, side effects and allergies are completely different. Look at family history. What kind of risk factors do they have? What kind of medications they're taking, and environment as well. With physical exam, you're going to look at the skin, mucous membranes. You're pretty much going to do a head to toe. And just keep in mind when you're assessing the older adult, because we are asking them to cough, deep breathe, go here, go that. Keep in mind their age and their aging process, because you don't want them to get too fatigued while you're doing this. Make sure that you do vital signs before you do their physical exam as well, to make sure they're not currently having complications. We know that you're going to use your skills of inspection, palpation, percussion, and auscultation. Here we go. We have a question. So a patient complains of chest pain. When assessing the pain, you decide that the origin is cardiac rather than respiratory or GI when A, does not occur with respiratory variations, B, is peripheral and may radiate to the scapular regions, C, is aggravated by inspiratory movements, D, is non-radiated and occurs during inspiration. The answer to this is A. It does not occur with respiratory variations, because sometimes when people have pneumonia and respiratory diseases, if they take a deep breath in, they'll actually have some chest pain. So if we know that there's no relationship between them taking in breaths, then we know that it is a cardiac related. Here are some of the diagnostic tests that you will be reviewing with your patient. All of these play an important role. Um, you have more details in your text, page 836. Nursing diagnoses. These are important to make sure you're using the correct diagnosis for your patient. Implementation and health promotion. It's important that we educate our patients and their families about vaccinations. We have the influenza and pneumococcal. Remember, with flu shot, it is recommended for any kids that are 6 months and older, and for those with chronic illnesses. The pneumococcal vaccine is usually recommended for anyone that's 65 years or older, or if they're at high risk for pneumonia or have some kind of chronic illness, or they have immunocompromise, such as people with AIDS and HIV. Healthy lifestyle, eliminating risk factors, eating the right kind of foods, getting enough rest, which is hard to do when you're a nursing student, but try to get in at least 6 hours. Even exercising is good. It's important not only for your overall health, but studies have shown that if you do a little 20-minute walk before a test, your brain actually functions better than if you were sedentary. And environmental pollutants, again, like people that are painters, farmers, we have to educate them to make sure they're using the proper mask with HEPA filters in there, so they're not breathing in chemicals. Now, as far as acute care, all of these different things such as hydration, humidification, nebulizing, all this helps. CPT, remember, just with CPT, it helps loosen up secretions. It's important that if your patient is able to cough up their secretions, let them cough up their secretions, but if they are not able to cough up their secretions, then you need to help them with suctioning. With dyspnea, it's always a little difficult to measure and treat. Treatments are individualized, and there's more than one therapy that can be implemented. Airway maintenance requires mobilization of secretions by increasing fluid intake, humidification, or NEBS. Breathing exercises will improve ventilation, oxygenation, and sensations of dyspnea. The airway is patent when the trachea, bronchi, and large airways are free from obstructions. Proper coughing techniques will help the airway stay patent and free from obstruction. The ability for patients to move their pulmonary secretions makes a difference between a short-term illness versus a long-term illness. Remember, we want these patients coughing up, deep breathing. Pulmonary secretions that are white and thin are usually easy to remove with minimal coughing. Humidification, anytime your patient is on 4 liters or greater, humidification must be applied to your patient. Bubbling oxygen through water adds humidification to the oxygen. It helps patients too. It won't dry up their nares. It won't give them any nosebleeds, and it's comfortable for them. Directed coughing is a maneuver that is effective with spontaneous coughing is not adequate. Diaphragmatic breathing is a technique that encourages deep breathing to increase air to the lower lungs. And CPT used to mobilize pulmonary secretions. They add pulmonary drainage, chest percussion, vibration. All of this will help your patient loosen up their secretions. And this, remember, is something that can collaboratively be done with respiratory therapists. Here goes a picture showing some percussion. However, keep in mind that percussion is contraindicated in patients with bleeding disorders, osteoporosis, or fractured ribs. Suctioning techniques. With suction, like I mentioned before, it is done when patients are unable to clear their own secretions. So, but it's necessary when, like I said, they're not able to cough them up. You have to go in there and get the secretions out. You can either do it through the oral airway, nasal suctioning, oral tracheal suctioning through an artificial airway, which is your endotracheal tubes. Each type of suctioning requires that you're going to use a round-tipped flexible catheter, and it's going to have tiny little holes for it to be able to withdraw out the secretions. When you're suctioning, you apply negative pressures, but nothing greater than 150. And during withdrawal of the catheter, you're going to be applying suctioning as you're withdrawing, but never upon insertion. You're going to learn various ways of suctioning techniques in the lab. You will be able to see the difference between when you need to use, when it has to be sterile and when it has to be clean. If you're suctioning your patient too much, they're at risk for hypoxemia, hypotension, dysrhythmias, or trauma to the mucosal layer of the lungs. Make sure you limit your trach suctioning, any suctioning, to 10 to 15 seconds. Anything more than that can cause your patient to become short of breath and dyspnea. This one here, this is a picture of a ballard. This is usually connected to an endotracheal tube. It can also be connected to a trach. It's a nice method. It's closed. It's easy. It's because it's a closed line suctioning, you don't need to put on sterile gloves. You can simply put on regular gloves and go hyperoxygenate your patient and suction when they're ready. With artificial airways, we have oral airway, we have endotracheal and tracheal airways, and we also have tracheostomies. With the oral airway, this just prevents obstruction of the trachea by displacing the tongue into the oral pharynx. Many places where I've seen these used is usually in the recovery room. If a patient was extubated and they're having a difficult time staying awake, many times they'll put in an oral airway to prevent the tongue from going to the back and blocking their airway. With endotracheal and tracheal airways, these are short-term, and it all depends on the physician on how long they actually want to keep this artificial airway in. Sometimes some physicians can push it up to 14 days. After 14 days, they start worrying about the tissue around the tracheal area because it can become necrotic. So this is usually if an endotracheal tube's been in there for 14 days, they start talking to family about doing a tracheostomy. One of the complications with tracheostomy is partial or total airway obstruction, which can be caused by buildup of respiratory secretions. For those of you that have taken care of patients with tracheostomies, know that they have a lot of secretions. Usually you can hear them as they're taking breaths in and out. This one here is your artificial airways. That's an oral airway that we talked about earlier. And the other one is showing you a picture of an endotracheal tube. So if you can see around the throat area, there is a balloon that's being held in with a balloon, which is why this tube cannot remain in the trachea for long periods of time, because that balloon itself can start causing necrosis around the tissue. Of course, we always talk about the things that can help our patients with lung expansion. Ambulation is always a nice, easy method of helping the lungs expand. That's why whenever your patient can ambulate, early ambulation shows that there's a lot of benefits to your patient's general health and their strength and their lung expansion. Positioning is very important. The most effective positioning for lung expansion is 45 degrees or a semi-Fowler's. Many places they can go as low as 30 degrees, which would be your intubated patients that are on feedings and things as such. The position plays a big role with gravity and how it assists you with lung expansion. And keep in mind if, let's say for example, you walk into your patient's room and your patient is telling you they're short of breath, one easy quick thing you can always do is raise the head of the bed. And after you raise the head of the bed, you can go and get a pulse ox and do a set of vitals to see how low your patient's saturation is, or if this is affecting their heart rate or their blood pressure. IS, incredibly important after surgery. Make sure you always teach your patients to use IS. IS is used 10 times every hour while awake. Make sure that your patient can demo how to use the IS. Many times they'll be pushing air out and not air in. I'll tell them to um, pull air in, such as if they're sucking on a shake or something. Then you have what they call NPPV, which is non-invasive positive pressure ventilation. This one is used to prevent the use of artificial airways or endotracheal tubes in patients with acute respiratory failure. Usually, we do not like to intubate patients with COPD, primarily because it's going to be very difficult to get them off the breathing machine. So sometimes what they'll use is a non-invasive positive pressure ventilation. Some of you have heard it as BiPAP. This helps prevent atelectasis by inflating the alveoli. Also reduces pulmonary edema by forcing fluid out of the lungs because it's going to keep the alveoli open, and that fluid goes back into the circulation. It also improves oxygenation and sleep apnea. There's a lot of people that will use these BiPAP machines or CPAP machines because they have sleep apnea. Ventricular support is achieved using the different methods, like I said. With CPAP, what you're getting is continuous positive airway pressure. With BiPAP, you're getting a bi-level positive airway pressure. So they're both positive, but CPAP is continuous and the BiPAP is bi-level. Here's just a diagram showing you IS and the other machine. The other picture is showing you the CPAP machine. There's different versions of masks. There's big mask, little mask. Here is another question. So this one's a pretty easy one because their answer is in the question. A patient with a tracheostomy has thick tenacious secretions. To maintain the airway, the most appropriate action for the nurse includes: so are you going to suction through the nose? Are you going to suction through the mouth? So if you go back and you read the question again, it says tracheostomy. So your answer is A. Yes, you're going to do tracheal suctioning. So maintenance of and promotion of lung expansion. Well, there is chest tubes out there, and the reason why we use chest tubes because we either will use them for a pneumothorax or a hemothorax. And what it is, it's a catheter that is placed through the thorax to remove air if it's a pneumothorax, or fluid if it's a hemothorax, from the pleural space to prevent air from re-entering or re-establish intrapleural and intrapulmonic pressures. Chest tubes will be discussed in 201, but it's important to start getting a good understanding of them. There's different types of chest tubes. There's closed system, and there's single chamber, and you also have dry suction, and you also have wet suction. The newer types of dry chest tube systems, which do not use water in the suction chamber, they have an automatic control valve, what they call an ACV, and balances the force from the atmosphere into the chest tube. And maintenance of oxygen here is talking about different oxygen therapy, and your book does go in some depth into this, and your little book for your fundamentals ATI book has good information on if you want to refresh on the different types of masks and things like that. Remember, the goal is to make sure that we prevent hypoxia, and we want to deliver oxygen at the lowest level possible with the greatest concentrations. In other words, we don't want to over oxygenate our patients. We want our patients to get just the right amount. We want to prevent and relieve hypoxia, but at the same time we want to do this safely. Remember, oxygen is considered a drug. With things such as masks, and when it comes to types of masks that we haven't used often, you always want to collaborate with a respiratory therapist. The nasal cannula tends to be one of the most simple, comfortable methods we use for oxygen delivery. Then you have an oxygen mask, which fits really nice and snug over the mouth and nose. Some people don't like the mask because they feel claustrophobic. So here's a picture of a mask, and if you look at both of the masks are different. So the mask on the left shows you just a simple mask. A simple mask can deliver anywhere from 35 to 50% FiO2, and FiO2 is fraction of inspired oxygen concentrations. You can do flow rates when it comes to liters. They have to be 5 liters or greater. So you cannot have a mask on a patient with 2 liters. It has to be 5 liters or greater. If you do not do 5 liters or greater, you're actually going to have your patient continue to rebreathe CO2 in the mask, and we are trying to help them not worsen their condition. Then the other picture shows a non-rebreather mask. With this one, you can give your patient anywhere from 40 to 70% FiO2. This flow has a minimum of 10 liters. So usually, um, although your book will say you can have a flow rate of 6 to 10, when you're using a non-rebreather, it's recommended that it should be a minimum of 10, and it will deliver anywhere from 60 to 80%. Always inspect your masks and your tubing when you put oxygen on your patient. Then you have the Venturi mask. The Venturi mask, to be honest with you, in my facility we don't use this as often, but with the Venturi mask you can deliver anywhere from 24 to 60% and flow rates of oxygen anywhere from 4 to 12 liters. And of course that's going to be based on your doctor's orders. You will have people that will go home on oxygen. Some of your COPD patients will require home O2. They have to qualify for this home O2. Many of these people will have to get an ABG on room air, and it's usually after exercise they have to be at 88%. Or if their arterial partial pressure, their PaO2 is 55 mm or less. Also, if they have a T-tube or tracheostomy, or if they have any kind of chronic cardiopulmonary diseases. Okay, and here is a question. So you're evaluating a patient post-thoracotomy. That means there was a lung removed. This patient has a chest tube. The best method to properly maintain the chest tube would be strip the chest tube every hour to maintain drainage. No, stripping the chest tube every hour can cause damage to the patient's lungs. That's contraindicated actually. Place the device below the patient's chest. This is a chest tube, so yeah, that sounds okay, but let's read our other choices. Double clamp the tube, except during assessment. Nope, we don't want to clamp the tube. Remove the tubing from the drainage device to check for proper suctioning. No, you don't want to be taking your chest tube apart and inspecting. Once it's connected to the patient, you don't want to do that. So our only choice here is B, and yes, B is the correct answer. Okay, in this slide, I am showing you the new CPR methods, which is called CAB. We no longer go with airway, breathing, and circulation. We actually do circulation first, which means that if your patient is hypoxic and is severe prolonged hypoxia, they're going to go into cardiac arrest. And once your patient is in cardiac arrest, you're going to do CPR. So you're going to start doing chest compressions immediately, because the new studies are showing that once you initiate chest compressions, you're already delivering a little bit of the oxygen that remained in the body versus wasting time looking for something that can be dislodged like airway. So the sequence for your CPR changed. Ventilation now is done after the first 30 cycles of your first cycle of 30 chest compressions. And all of you have your CPR card, so you're familiar with this. Restorative and continuing care. This is just cardiac rehab, controlled physical exercise, nutrition, counseling. All of this is important when we send our patients home. We want to help them achieve and maintain an optimal level of health. We want to make sure that they are hydrated to keep their mucus clear and thin. But of course, if it's not contraindicated, they should be having, patients should have anywhere from 1.5 liters to 2 liters a day. But of course, remember, yeah, make sure that it's not contraindicated for your patients. We do teach our patients how to do pursed lip breathing. That helps with their breathing techniques, helps them bring in more oxygen. And then there's different types of coughing techniques we can teach our patient. There's your book will go into some. The type itself is not important. You're not going to be questioned on that. With pursed lip breathing, remember, it's like a deep inspiration, prolonged expiration, and it helps prevent alveoli collapse. This is why a lot of our COPD little patients will automatically do pursed lip breathing. And then with diaphragmatic exercises, that helps. It requires a patient to relax. It helps with the accessory muscles by taking in deep inspiration, so it helps the patient breathe better. Now, our nursing process, and we're going to evaluate. So we're going to find out, okay, did our patient establish the perfusion that they needed? We're going to look at the degree of breathlessness. How are they breathing? Are they breathing normal? Are they tachypnic? Were they able to ambulate? If they ambulated, did they become short of breath or fatigued quickly? You can rate their breathlessness anywhere from 0 to 10. Then you can think about interventions that can help reduce shortness of breath, frequency of cough and sputum. All of these things you're going to be evaluating. Safety guidelines. Patients with sudden changes in their vital signs, you need to assess because something is going on with them. Level of consciousness, remember, is always the first thing that's going to change, or they're going to start behaving a little wacky on you. So make sure you assess that and make sure they're not hypoxic. You would want to call your doctor, and hopefully your doctor, you can recommend an ABG to see what their oxygenation is. Perform tracheal suctioning before pharyngeal suctioning whenever possible. Use caution when suctioning patients with head injury. And then the routine use of saline going into the airway is not recommended. You will still see some respiratory therapists do this, but it is not recommended anymore. There's multiple studies to bunk this, so it's really not a practice in nursing. And of course, always check your policy in your hospitals before you're stripping or milking chest tubes, because not every hospital will allow you to milk and pinch chest tubes. Do not administer oxygen at more than 2 liters unless a healthcare provider order is obtained. So you do have the ability to do 2 liters. But anything other than that, you need to get an order for. And you do need an order for the 2 liters, but you can initiate it and later get your order. And of course, here is my quote: if it was easy, everyone would do it. That's why not everybody does it. Remember, nursing is a challenge, but it's well worth it once you finish. If you have any questions, please email me or talk to me before your quiz next week.